want to thank everyone for joining us today here on our town hall. We're very privileged to have Dr. Michael Lozardo with us today. He's an associate professor in the Division of Infectious Diseases and Global Medicine in the College of Medicine, been with us since 1997, but his real claim to fame is as director of the Screen Test and Protect program. And so I appreciate folks sending in your questions in advance. In addition, we have a Q&A box here. You can send them in during the meeting, and I'll try to get to them as well as the ones that were submitted in advance. But I'd like to start with Dr. Lauzardo to give you a chance to make an opening statement on how things are going. So the floor is yours.
Great. Thank you so much. And thank you all for coming once again and for inviting me to share with you all one more time. Again, good afternoon, everybody. I think trying to remember the exact time, but I think earlier in one of the previous town halls with all of you, I had, kind of shared my, feeling of optimism and feeling, that the challenges in front of us were great. And then we had a lot to be optimistic about, that there was what I called grounded optimism, that certain things needed to be in place for me to feel that we were going to be in a good place, but that ultimately I felt confident that things were going to work. For things outside of my control and outside of all of our control, there is an enormous amount of things to be thankful for, not the least of which are the presence of the vaccines, which for us in many ways represents, as I've been kind of using the metaphor, the medical cavalry being here and arriving onto the scene to help us out. But despite that, there's obviously some real big concerns. Just look at the news today and kind of the reality of what's going on around the country in terms of the number of cases, some of the impact of cooler temperature driving us indoors, holiday gatherings, some people just getting tired of dealing with COVID and maybe some relaxing of the measures that we've been taking up until this point, I think are all seem to be conspiring to try to deal some knockout blow right before the time that help gets here. But despite that, again, I'm going to spend the bulk of the time obviously answering your questions and your concerns and validating those concerns. Looked at the questions again, and again, they're not easy questions, and they're valid questions. And the concerns and quite frankly, the anxieties that we all share are well-founded in many instances. But also, again, want to point to the facts and kind of point to what our risks really are, point to where our sort of help will come from, and to know what to expect, or at least our best guess as far as what to expect as we move forward. So again, my optimism has been strengthened since the last time we met. I think there's now where we can start to see the end of this, but there's still at least one more big heavy lift to go. Again, sticking by our guidelines, sticking by the things that have gotten most of us to be safe and to be able to get through this time. We need to stick by that and sort of double our resolve to be able to get there. And we'll get there. And then we can start planning for a post-COVID world and a post-COVID recovery to be able to get to the other side. So with that, again, I will be a tireless optimist, and I'm going to base that on the facts that are in front of me. I'd be glad to start taking all of your very good questions. So some of those that were submitted ahead of time, I had a chance to look at them, and they're great questions. So I'll do my very best to answer those and hopefully kind of get us on the right path here. So anyway, so Rob, whenever you're ready, I'm ready to go.
All right, very good. Well, there are three different themes that emerged from the questions. I think we'll take them in this order. There's questions on the STP program this semester, how it functions and lessons learned. There's other groups of questions on what we're expecting in the spring when we have more students returning on campus, more face-to-face classes. And then I want to end on the optimistic topic on vaccines and development, leave everybody with a good taste in their mouth. So we'll do that one at the end. So we'll start with on STP program. One of the questions was regarding assistance, and they stated that when they called with questions on epidemiology, for example, who should they call? How can they get assistance on getting their questions answered in STP? What is the number, and how should they reach someone to call?
Yeah, no, that's a great question. I saw that one there as well in the sort of the pre-submitted questions. So first of all, I will say one minor correction is that you want to end it on an optimistic note. And I agree that the vaccines are probably the foundation of a lot of our optimism, but I think there's a lot of optimism in the other questions as well, as kind of what we've learned over the semester and what our plans are for the semester coming. I know that's a source of significant, appropriate, and understandable anxiety, but hopefully we'll kind of address that with some things that we've learned that can hopefully put people's mind at ease. In terms of the questions, I would recommend calling our office directly and say that I have these specific questions and ask to speak to one of the epidemiologist faculty staff. So it's myself and a couple of other folks that are here, and we'll answer questions. If it's something about a direct investigation or about an exposure, our disease investigators can handle that. And then also, if you have a problem where you're not getting the answer you need, just send me an email or a text. So our office number is 352-273-9790, and that's 352-273-9790. And you can call that number and ask those questions. Say, I have a question about X, and we'll kind of find someone to answer that for you. Like I said, if it's investigation related or an exposure, some of the other disease investigators will be able to handle that. You can email me as well if it's something that can wait a day or two for me to get to you. And I'd be glad to do that. And also you can email or request my cell phone. I give you guys that as well if you want to text me with that. People have been really good when I put that number out. So just if you don't mind, text me instead of call, just because it's just hard to keep track with everything. But my cell phone is 352-317-5162. That's 352-317-5162. And then just text me if it's something that you think needs to be taken care of more urgently. But we should be able to answer those questions, and we're really very much enjoy asking those questions. We have departments around campus do that. Again, not to overpromise here, so I want to be careful, but and I know with you guys being spread out over a much larger geographic area, it may be more difficult. But for those of you on campus who might have questions or nearby, we've had staff go kind of address specific questions if there are questions about the physical environment or wanted to kind of us to inspect different things. So we're doing everything possible to kind of address concerns that are out there. So feel free to reach out to us. We aim to please, and we see ourselves as your servants to help you keep doing your jobs that you guys kind of got trained and want to do.
Thank you. Thank you very much. The next question has to do with the methodology behind the numbers on the dashboard. And so what I'm going to do, I hope this works, I'm going to put the link in the chat, which should go out to everyone in case you don't have the link to the dashboard. And so there was a question specifically how those numbers are derived on total UF affiliates, the testing numbers. Maybe you can discuss the methodology behind those.
Yeah, so there's three different ways to where, and I had a little trouble understanding the specific aspect of the question about how there was 3 fewer cases. I think the following day was what I saw in the pre-submitted questions. I will tell you the methodology behind the questions behind the dashboard and how we count cases, and sort of I'll answer from the 10,000 foot view rather than to get into the weeds about a specific question. But you can count cases in 3 different ways. So you can count that from the date of onset of symptoms is the date that you count the case on that given day. And frequently you don't know that until you look back retrospectively, right? So you get a positive test, say someone tests on a Monday, we get the result on a Tuesday evening, we see it on a Wednesday morning, call them, get a history and find out that their symptoms started on Saturday. So depending on what system you look at, if it's a system that's counting from when they tested, from when they got a test result, and it got recorded versus when we put that in as a date of onset of symptoms, it's going to vary. And I believe that our EPI curve that's on the website does it by date of symptom onset. And so that might fudge a little bit based on when it's tested and kind of the total numbers. They'll all be very close, and they all kind of tell subtly different things that we kind of as EPI folks following this give us a little bit different information at different times. So that accounts for some of the discrepancy in the counts. Also, some folks will, be listed as probable cases, may get subjected to get kind of counted in a certain way, then get pulled back. So those are the subtle differences where the numbers are not hard and fast in stone. You would think that, you're counting things, right? There's 5 apples on your dinner table and you count the 5 apples and there's no reason why it should be 4 or 3 or 6, you count the 5. But this is a little bit more of a dynamic process. So a lot of people think that that somehow indicates inaccuracy or a lack of transparency, but that wobble around those numbers just depends on exactly how those cases are being counted and how we address them. And that's probably with any dashboard and any data set that's out there. And so the same would be true of ours. And I hope I adequately answered the question there, because those subtle variabilities that are there really, if you're a forest guy like me instead of a tree guy, I'm okay with the big picture. And so I can kind of live with that. The details can be kind of cumbersome for some folks and kind of worrisome, but it really just has to do with adjustments in the numbers and when the cases are actually counted and how they get into us.
Thanks. Next question is on quarantine. This came up at another meeting I had this morning at an REC about a director and issues on whether they should quarantine international visitors that were coming in. And the question here is, why is it no longer required for UF employees to quarantine or be tested when returning from out-of-state or international travel? So would you like to talk about our policies in that regard?
Yeah, I think we're going to relook at those depending on where the epidemic is. What we have done in the past and are still doing is whatever the state of Florida requires is what we've been requiring in terms of quarantine and isolation from various different travel. I think in general, so we follow whatever the governor's executive orders are with regard to travel, we follow that. Now, there are other wise things that you can do. So for example, many of you may have heard those members of the White House Coronavirus Task Force saying that if you've traveled and met with family over Thanksgiving, you should consider quarantine and isolation, or quarantine rather. And that's not bad advice. So self-quarantining during that time, if you may have had a risky exposure or higher risk travel, it's a judgment call, and that's why we refer to it as self-quarantine. But we'll revisit that depending on what the epidemic does over the holidays. And then for the spring semester, we'll give more clear guidance depending on what the situation is at that time. At present, we just, again, like I said, follow the executive orders of the governor and otherwise just kind of evaluate people if there's a known exposure to what they've done. The key thing, probably the single most important thing people can do, if you know you've been in contact with a case, self-quarantine. Also, if you have any symptoms, stay home and then get tested and self-isolate if you have symptoms until you get a negative test and are evaluated by a medical or public health professional.
Okay, thank you. There have been recent changes to the CDC close contact isolation period to 7 to 10 days after exposure. And so would you talk to that a little bit? What's informing that policy perhaps, and how that might affect what we're doing here at UF?
Yeah, so we will follow CDC guidance and we will follow that recommendation. And initially, the thought is that the incubation period was from 2 to 14 days. And that was based on a variety of different things. But most likely it was related to, in very rare instances where people can be infectious later on. But those were different sets of circumstances. And now with experience, we do know that now the testing has become a little bit more widespread, actually much more widespread than it was in the spring when some of these guidelines were first developed, is that we do know that those who test negative on day 7 are highly unlikely to be infectious any day past that. So if you've been exposed and you haven't developed symptoms, you have a negative test at day 7, it's very unlikely that you'll develop symptoms and become infectious after day 7. Extremely uncommon. In fact, in a smaller study right now that's about to be submitted that we did that with Alachua County school children and followed them and did their testing on day 9, where we were testing on day 3 and day 9 and saw what happened at day 9. And if they were negative at that point, they did not spread to anybody else and didn't become positive afterwards. And so there's been no impact about spread, and there's been nothing else that's happened beyond that. So again, the data, both in our own experience, but also data that's been published and that's kind of being circulated, is that testing negative on day 7 makes sense. If you're a contact and you don't test, but you're asymptomatic and it's day 10, you can then come off of or quarantine as well. There's an extremely remote chance that you can still be infectious under certain circumstances, and this assumes that you have a normal immune system or you're not known to be immunosuppressed, you're not on immunosuppressive medications, you actually do not have any symptoms. And in that case, we find that that's a pretty good indicator of risk. And so the benefit versus the risk is far in our favor to reduce the quarantine period. And that's going to have a significant impact to allow us to be able to get people sort of back to normal life and have it be less intrusive, and particularly in school settings where we can let children have more school days in the classroom.
Thank you. And a related question on this, if there are multiple household members who test positive, do those positive testing members need to quarantine from each other or stay away from each other, or can they be in contact at that time?
Yeah, you can cohort together. So in other words, we actually do that when in the high point of the epidemic on campus, we were cohorting students who are positive together. So that's something that can be done, and it's okay. Again, assuming that everybody is negative or positive, that is together and that there's no one who's immunosuppressed and continued infection. There's some exceptions, but in general, if it does get in your house and it's a family of 4 and all 4 of you have it, there's no reason why you need to isolate from one another under normal circumstances. So that's an important point, but yes, that makes sense.
Question here from the chat on restrooms, which currently have no occupancy limit. And the question is, why do we have occupancy limits for labs and offices, but not restrooms?
Yeah, it's a good question. I think initially there was a lot of concern about restrooms and the potential for spread in restrooms, and it's very minimal. But the amount of time that the average person spends in the restroom is going to be, not as much as we would consider to make them a close contact. And in general, that close contact shouldn't be happening in a restroom, and there shouldn't be that many. Now, again, how many people in a given room? We set limits on how many go in an elevator, and kind of that gets addressed. So if there's any particular site that's of concern, then we can kind of see kind of with facilities to kind of get that addressed and limit that. But again, there's no real clear guidance on that. And I think they're having 1 or 2 people in a standard office size restroom should not be unreasonable for the brief period of time that people are in there. Again, assuming that people remain masked, that risk should be markedly reduced. And again, with all the different caveats of different situations that we've answered so far and that we'll continue to ask, one of the things that we've learned is just the importance of masks. They work and they have a big impact. So that's part of the reason why the news about being able to get together indoors in certain circumstances, the routine things that we do when we're physically distanced, all of those things are made possible because of the use of masks.
Great, thank you. You mentioned close contact. Can you define that again for everyone, what it means to be a close contact of someone, the duration and distance?
Yeah. So in general, the primary guideline for that is that you are within 6 feet of somebody with known to have COVID for 15 minutes or more cumulatively. So in other words, it's not 15 minutes straight one time, because think about it, that's pretty uncommon if you're with somebody for 15 minutes straight within 6 feet, but it's cumulative. So if, like, let's say a colleague at work, you're looking over their shoulder at the computer, shoulder to shoulder, you do that for 5 minutes reviewing a graph, you come back, then you sit down at a table and you kind of have a coffee break with them and you're close to them within 10 minutes, that 15 minutes together is going to make you a close contact. It wouldn't be that you can do 10 periods of 5 minutes over the course of the day and it doesn't count. So it's going to be cumulative. And so then also it's going to be the eye of the beholder, the disease investigator. There are other sort of non-tangibles, and this is kind of frustrating to people because it gets perceived as being somewhat arbitrary or capricious in some way. But really, close contact gets defined of a bunch of other things that kind of get in there in terms of were they symptomatic, how close were they, indoors versus outdoors, masked versus unmasked. All these things have an impact of how close and how intense that exposure is. And remember, we don't care so much as labeling someone as a contact or not, or isolating or quarantining. We want to stop the spread of the virus. So in other words, if we think that there is a risk exposure, we'll make sure that that person is a contact and that they quarantine appropriately, because we're really trying at the end of the day to stop the spread of the virus and keep vulnerable people safe.
Okay, thanks. A very specific question here, which will wrap up our section on what we're doing right now. What CT do you use for PCR COVID tests? Does that make sense to you?
It does, yeah. So this is a very sophisticated question. So in other words, that's the cycle threshold or cycle time. And what that is that the PCR reaction is an enzymatic reaction that theoretically, the more virus you have present, the shorter the period of time or the fewer number of cycles the enzyme reaction has to get before you get to a threshold to call it positive. And so if you let that cycle threshold go very far out, then you can then become, call things are positive that really aren't. So in other words, it decreases the specificity while increasing the sensitivity. And in general, we go by what the what CAP and CLIA guidelines are, since all of our specimens go to the CAP and CLIA UF pathology lab. And there, I believe the cutoff is, I don't want to misspeak, I can't remember if it's 35 or 40, but I believe it's 40. We do not use the cycle threshold for any clinical decisions. There is some debate, and there have been some articles to say that, well, you're picking up a lot of people that were previous positives who are asymptomatic and they've got high cycle thresholds. And so therefore, you're not really picking up appropriate cases. These aren't really infectious. That's fine. But from a practical programmatic side, and to kind of implement this, we're kind of assuming that anything that meets the CAP and CLIA guidance as far as positive, we consider them, and we're not using cycle time really in a clinical sense. Now, there are some circumstances in the hospital setting and other things where that could be looked at, but for the screening public health purposes, we're not diving into the weeds too much on the CT values.
Okay, thank you. And another question just popped in too about the pros and cons of testing at CVS as opposed to on campus with UF Health. Could you speak to that, please?
Yeah, I'm a little bit biased on this one. So I don't see any pros right now to testing at CVS. I think that we get the results that, you don't have to pay through us. So you can also self-schedule. The turnaround time for us has been between 24 to 48 hours. And even though we've scaled up massively, it's gone up and worked out really well. CVS will not be the saliva test. It'll be either the NP swab or I guess, I don't know if they validated just the nasal and the nares on both sides. I'm not sure if they've done that or not. Then when the surges come, their turnaround times go way up. So for example, with what we anticipate will probably happen later this month, their turnaround times when a similar surge happened in midsummer and then also around town in September when we had our surge in September, turnaround times there were about 4 or 5 days. Ours weren't really impacted. We were able to turn things around, with exceptions. There are lab errors and things that happen, but our average turnaround time is probably somewhere about 36 hours. So I don't really see the big advantage to going off campus. And then also some students kind of thought that, not to cast any shade on students, I love them and I'm a father of a college student, so I get it. But some of them would go off campus thinking, oh, I'm not gonna get picked up and I don't have to isolate or quarantine, but I'll know what to do and I'll do the right thing on my own. The way our system is set up, we get all of the results from any site in the state of Florida that will get reported to us. And we cross-match that with UF Masterlist. So we're gonna know. So it's a lot easier to kind of follow things through. So we're functioning like the health department does. And again, our goal is not to know or rat anybody out. Our goal is to kind of stop the spread on campus and to try to protect people who are vulnerable as much as we can.
Thank you. Well, let's shift now to talking a bit about going forward for the spring semester. One question that came in is, understanding is that students are leaving for Thanksgiving and are not to return until January in most cases. How will that affect the testing offered weekly, and how soon will testing pick up again after the Christmas break when they're back?
Yeah, no, these are great questions. And if I may, I was going to just give a little bit of a sort of acknowledgement here, is that one of the things that has a lot of faculty, not so much in IFAS, at least from the feedback that we've gotten, but from other colleges, is that people are very, very anxious, faculty in particular that have maybe been off campus since March, very anxious about returning to the classroom. And that's an understandable concern, especially for those who might have loved ones at home that might have risk factors, or they themselves have risk factors. I understand that, and I'm sensitive to it. I care about that concern, and it's hard. I think one of the things that wasn't communicated very well from all public health authorities early on, and I have to unfortunately throw myself in that group as well, is that we really didn't communicate with people enough about how difficult some of the decisions will be that we all have to make. We all have to. It's not going to fall on just public health people or physicians or other officials. That we're all making difficult decisions from day to day. So one of these is about getting back to work and where you are and how safe you'll be. And those have been challenges that are very challenging and difficult. So in light of that, I think that these are one of those very difficult decisions for people. But what we're trying to do is to kind of really reassure people with facts and the data that we have, the experience that we've had from all the face-to-face classes and face-to-face interactions that we've had over the fall, which have been many. I forget the exact percent, but I want to say it's just 30-something% of what it normally is. So we have a large sample size to know what's happened over the fall and use that as our guide for the spring. So I hear and I want to learn more about people's concerns and address those with the facts and data that we have, and also know that there's a commitment from us that if we see something that isn't right, so in other words, if there's spread from a certain action or something's going on, we'll stop it. You know, it's like if there's a class or a certain activity that leads to spread, we'll stop it. We'll tell them, don't do that. Do these things instead, or just cancel that, or go online, or do whatever it might be. We'll go that route. There's no disincentive for us to be able to do that. And we've made that very clear to leadership, and they've been receptive to pretty much everything that we've asked them to do. Now, to get more specific about the Thanksgiving and the break over the 2-month period of time, people will still be able to get tested. And even though it is a 1-week questionnaire that comes out, if you want to get tested, let's say you do the questionnaire on a Monday and you just say, no symptoms, I'm fine, not a contact. And then but you want to get tested anyway, you can get the test. And then you really get exposed later in the week and you say, gosh, I'm really scared. I want to get, or I now have symptoms. And even though I was tested on Monday, I want to get tested on Friday. You can still do it. Just we reset things very easily. So you can go to 1.uf.edu and get tested. Now, there are some people get tested more frequently. We don't want people to get tested every day. And we don't think that there's a need to get tested every week necessarily, especially for low risk individuals. But we have made it to where people can continue to get tested. So we're not going to lock people out. Testing has never been easier on campus, and it is completely free. It's something that's part of our surveillance project on campus to be able to kind of monitor campus and to make sure we know what's going on so that we can direct our activities appropriately. Over the 2 months, the impact for the spring is going to be is that we're going to do a lot more testing. We're going to be testing in the face-to-face setting. We used our experiences over the fall to determine which risk groups are going to be the highest and need to get tested on a routine, regular basis. And then we also threw in face-to-face, not because they're significantly higher risk. In fact, we did not see them to be higher risk as a group, but we know that there's a lot of anxiety and worry about that. So we've included those students that are going to be in a face-to-face setting on the Gainesville main campus to get testing on a regular basis. So that's what we're prepared to do. We're going to have plans to do 2,200 tests per day, and then just cycle through at least through 3 incubation periods of the virus. We're now referring to the incubation period as 14 days still. So we'll call it, with the new guidance, we're not going to change that. We'll still go at least 6 weeks into the semester to then determine what the numbers are, and then see if we need to pivot and change off of that. So I think that's kind of formed the basis. We're trying to have our basis of our plan for spring, which is really, at the end of the day, what most people really care about. What are we going to do in the spring, especially in light of the news that people are reading now about what the holidays will be like? And we'll be ready. We'll be ready with increased testing. We'll be ready with routine testing, as well as everything else that's kind of behind it. Robust contact tracing and disease investigation, wastewater epidemiology to help guide what we're doing. All these different components that will be there, and the targeted testing that we do around contacts of cases when we identify them. So again, we'll be ready for the spring, and I think we're in a much better position now than we were in the fall.
You mentioned concerns of faculty. That's certainly been a theme that we've all been hearing. Can you talk a little bit about workplace transmission and what we've seen so far and learned about that as opposed to cases outside of the workplace?
Yeah, and that's a great question. So every day we're making our ability to detect things more robust. So in other words, we now have maps that tell us how many classrooms and sections have cases. We have maps of kind of where they're geographically located along with the numbers of cases, and we go through them and see what might have been going on and can go back and re-interview and re-investigate them. We're doing sequencing now of viruses. So the first batch of sequences from cases on campus are now being requested. So we should be able to get that hopefully in the next few weeks done to be able to analyze that data. But all those things together, we have not seen transmission on campus from academic related activities. Now, a few caveats to that. In certain clinical settings, we have seen that. We have seen it in social settings of individuals who work together or go to class together. But then when we investigate, we say, oh yeah, we had a dinner party, nobody was wearing a mask. And we, there were only 12 of us there. And we had, 6 hours, we thought we'd be okay, but nobody wore a mask and we had a dinner party. That's a very common setting. Then there's the obvious, more egregious things that we see with some, and a very small minority of people that are going to bars and living like there's nothing the matter. And then there are those that that get exposed outside. A family member comes or some other exposure, but we do a detailed interview, 30 to 45 minutes with each case to try to understand what was there in terms of transmission. And quite frankly, we're not seeing that level of transmission. And this is new data that we're trying to get in a more comprehensive package to share with everyone. But this is stuff that we've been able to get over the last several days. But there are 1,167 faculty and staff that are in face-to-face classrooms. And of those 1,167, we did tests on 441 of them. The others either didn't get tested or got tested somewhere else, but did not report symptoms, But of that cohort of 1,167 face-to-face classroom professors and faculty, we have 2 cases. And those 2 cases were not from classroom transmission. So in other words, you have the lowest positivity rate of any sort of group of UFs, I say flavor of UF people throughout the enterprise. The lowest positivity rate amongst that group has been amongst those professors and staff that are in face-to-face classes. Now, again, there's a lot of things we look into that. We're diving into the data. I don't want to say it's impossible and that it won't happen. These are all the kind of footnotes to what I just said, right? So, and also, there's a good chance I could be wrong and that something could happen. That's why we're looking. That's why we have everybody poring over the data and trying to see where this is, and then shutting down those activities where the risk might be. Also, bear in mind that we say face-to-face classes, right? But it's just like saying, oh, those people are foreigners, right? So it's just, everybody's different. It's a big label. So when you look at face-to-face classes, that means a lot of different things in a lot of different settings. It could be a professor in a physically distanced room giving a history lecture to 8 people physically distanced, or it could be a music professor with a woodwind student 10 feet away, generating an aerosol while they're playing the oboe. So those are very different settings, but they fall into face-to-face. So we're looking at the data clearly and very closely and kind of making our adjustments based on the risk. But even with that, we're noticing that really that transmission in a classroom setting, in the face-to-face setting, is not something that's there. Now, again, we're doing our best to kind of find that. There's no reason for us to not find that. If there is, we can shut down specific activities or step things up to see it's there. But again, wearing masks, physically distancing, staying home if you're sick, washing your hands regularly, enforcing those rules makes sense, and it stops transmission. So it's not magic. It's not just good luck. It's not sort of smoke and mirrors. It's like the stuff works. And so there'll be exceptions, and we're ready for those, and we'll keep looking. And if something is not right, we're going to tell folks. We've done some deeper investigations on campus when we saw I want to avoid the use of the word cluster, because epidemiologically that's a very meaningful term. But when we've seen groups of cases disproportionate in certain areas, we've gone in and looked and dove in deeper. And so we don't know much about upper campus in terms of what the classrooms were like, but we found this one chemistry class that had a lot of cases in it. Then we found out that chemistry section had 1,500 students in it. And so then our temperature went down a whole lot when we saw that, and then went back and did some investigations, and then we're satisfied that, and then did kind of observations, I guess would be a good way of doing it, to show and to look and see what adherence was to guidelines, and they were doing great. And so even with all those assurances, that's still not good enough for us. We're going to go back and then look at the molecular epidemiology. In other words, sequence those viruses to see if maybe something slipped through that we weren't aware of. And so again, we're looking very diligently to really know whether or not there's any transmission in those settings, because we're almost to the finish line. The vaccines are around the corner, and I'll talk about that here with the next set of questions. But really, we're looking really closely to look at this. And again, doing so, I don't know a better way to say this, with a spirit of humility. It's like, we could be wrong. We could be missing something. And so we're poring over this to just make sure that people are not getting exposed to without our knowledge. We want to know what's happening. We want to protect people and give people what they need so that they can feel confident just to do their jobs. And that's really what we want to do.
So we mentioned the data from the workplace. Another question here is about student behavior outside the classroom as a factor in transmission. And have you looked into other measures that other universities have used have been successful in moderating that behavior? And will you have to consider an honor code or some type of other measures in working with our students to try and reduce the spread of COVID?
Yeah, no, those are great questions. And I'm going to stay in my lane. Those are more student affairs related questions, but I'm not going to dodge that and just say that's a student affair thing. Next question, please. But we've been in a lot of discussions to try to address that. Human behavior, it's a false assumption. I learned this a long time ago, but it's a difficult lesson to learn, is that, to assume that human behavior will change with education is a hopeful aspiration, right? So it doesn't always follow, especially in this age group and especially with certain individuals. So there have been bad behaviors, and we've tried to address those. The city and the county working with the university have worked very closely to try to get that. They've mitigated some of it. Some of it did lead to spread in the dorms and Greek housing and other social settings as well. We think that with isolation and quarantine and enforcing the mask, the impact on the campus activities has been minimal, if present at all. And we've found that that's been helpful. Now, in terms of the other things, the issue of an honor code has come up before, but I'll ask Dr. Mull about that again to see if that is something that's being considered. There are pledges that was put in place, and the student pledge, I believe, was kind of a not pioneer, but sort of initiated by the student, I guess, student government, and that was initiated early on in the fall, and I think that will continue into the spring. But we'll kind of push that issue some more, and hopefully we'll start to see that have an impact. But I lose sleep over that. Trust me, I've driven through downtown just to stay oriented to person, place, and time to when I think when I think I would start feeling good about what we're doing, and then I drive by downtown and I see the lines in front of the bars, and I kind of just realize that our work is not done. So we just got to keep going.
Yeah, thanks for that. I know Gina Mastracasa has accompanied you and others. And I think what's happened is as soon as you step out of the car and walk by, all the students scatter there from the lines when they see you coming. So
yeah,
you must be well known downtown, I assume.
Yeah.
I guess one other question here before we move on to vaccines is we're going to wrap up testing in the spring. What about cleaning as well, as we have more students coming in the campus? Are there plans then to ramp that up as well? And then how is that handled in general? Is that something when you find out there's been a positive test, who is the one who then organizes with EH&S and others about the cleaning of those facilities?
Yeah, and there's I don't want to misspeak. There's a set process in place in terms of how it gets triggered. It's usually through HR, and there's sort of like a sequence. Our office does not get involved with ordering the testing. We kind of stay in our lane in terms of the disease control, and that goes through operations and through HR as well. The cleaning thing, the good news about that is that most of us were really concerned early on about the risk from the physical environment in terms of touch. And that's really not been it. It's been more about the air, and that's why the impact of masks has been greater. And so the need to clean a physical space after a person with COVID has been there is really nowhere near as big as what we originally thought that it was. And so a lot of those recommendations have been scaled down. Now, if you just wash your hands regularly, gel up if there's no, with hand sanitizer, if there's no soap and water readily available, those are the best ways to kind of prevent. But really the deep cleaning in the environment, really that's not necessary. And we're, to give you some perspective, the hospital stopped doing a lot of that very deep cleaning. Just do routine cleaning, and then washing your hands regularly is all that you need to really do.
Okay, excellent. That answered actually another question we have, which I'll check off the list on cleaning versus hand washing. One other one that's popped up is, IFAS is not just in Gainesville, but in every county around the state, many different research centers. And someone has asked, what is your opinion of rapid testing versus Department of Health testing? Do you feel rapid testing is reliable?
Yeah, I'm going to be more of a fan of PCR testing when you can get that done. Rapid testing makes sense if you've got symptoms and you need to know now, right? So in other words, for whatever reason, so you can't move or you're with someone who's at risk, and isolating and quarantining would be too much of a challenge and you need to know now. The tests, the rapid antigen tests, are FDA approved. In other words, they've been studied best amongst those who are symptomatic and have an epidemiologic risk. They're not very helpful for asymptomatic folks. In other words, hey, I just want to get screened to make sure that I'm okay. The rapidity is really the only advantage to that. Now, and scaling that up from what the side of point of view of what we do is not easy, just because it's hard to get a lot of those tests done at one time. In terms of the Department of Health as an alternative option, they've got a great testing platform, and their turnaround times have generally been good. Some of the sites that do the farm out kind of a thing that go beyond what the DOH's capacity has been not as good. So depending where in the state, it's been an issue. So one of the things I was going to say in terms of testing for the offsite folks, IFAS is a little bit actually very unique. Even though a lot of colleges have other offsite facilities, you guys kind of set the standard for being all over the state, right? In so many ways, with thousands of people at offsite locations. So I think we'll just have individual discussions probably with with yourself and then also with Gina to kind of see how we can best serve your guys' needs. Overall, you guys are fortunately low risk. You're not popping up on our radar as big sources of transmission, but you do have unique situations such as the internationals and the dorm settings that you have, and some of the face-to-face settings that will be higher risk than average. So we'll engage in discussions over the next couple of weeks and have your individual plans set up here in the not too distant future.
All right, thanks. Well, let's move on to vaccines now. And all of us amateur virologists out there have been very excited about reading about the Pfizer safety and effectiveness, and Moderna, even Sputnik 5. Apparently, there are all sorts of vaccines out there from all sorts of countries. So talk a little bit, were you as excited as I was reading these? Talk a little bit about your take on these vaccines.
Yeah, I mean, I am excited. You know, there's cautious optimism because I'm going to say something inflammatory here, but it's just vaccines never helped anybody, right? They don't. It's vaccination, right? So if people don't take it, if you don't get them into people's arms, if you don't figure out the logistics to get it there safely and effectively, they're useless, right? But this is a game changer. I mean, I'm super excited. And my cautious optimism comes from the fact is that we gotta finish, right? So this is the biggest news, the biggest scientific hurdle was overcome. Now it's a matter of logistics. So in other words, keeping the cold chain set, educating people, building trust. This is the fun part. We get to go on offense now, right? So now we get to get that vaccine out, and hopefully, God willingly, the vaccine will continue to be as safe in broader use as it was in the phase 3 trials that were done. And so hopefully the post-marketing data will be also as encouraging. But so far, I'm super excited. I mean, I think, remember, go back a few months and go back to like the late summer, early fall, and we were saying, hey, if we get a vaccine that's 50% efficacious, it's going to get FDA approved, and that'll be good news. We're 95% with the 2 mRNA virus vaccines that are going out there. So yeah, it's not just the medical cavalry coming. It's like we got the A team coming. So it looks very encouraging. Again, cautious optimism in the sense that there's still things that can go wrong. There's still some side effects that can go wrong. There's going to be we're still not only fighting a pandemic, but we're fighting the infodemic. There's a lot of bad information out there, and there are hackers. Some of the supply cold chain and supply chain networks were just hit by hackers recently. So there are a lot of little barriers, both seen and unseen, that we're going to need to deal with over the next few weeks. But the news is good. And really, to cap off the really good news, the first vaccine gets to Gainesville next Friday. Next Friday. This is wonderful news. And we're going to start seeing an impact on this very, very quickly.
Oh, that's phenomenal news. Well, we'll get into the how it'll be rolled out perhaps at UF here in a minute. So from your opinion, if someone's for the Dr. Lauzardo, here's your choice. You could have the Pfizer vaccine or the Moderna vaccine or the AstraZeneca vaccine. Does it matter? Do you have any concerns about one or the other versus on the safety profile?
Yeah, I think a couple things related to that. One, I want to look at the data myself. I don't want to claim that I'm going to have the level of expertise that the people working with the FDA and the real vaccine experts that are looking at that now, but I want to see it myself. I think a lot of us will. And then that way I want to be able to confidently tell people that, this is a good thing to do. And I think the best way to do that is to take it myself, right? So in other words, to just make that decision and go ahead and do it. Initially, we're not really going to have a choice as far as which vaccine we get, because the vaccines are not all going to hit at the same time. So the way it looks as of today, and I almost should say as of December 3rd at 3:45 p.m., the plan is this. Pfizer will hit the market first. There's going to be several 100,000 doses sent throughout the United States. The state of Florida is going to send the Pfizer vaccine to the 5 major medical centers in the major cities in Florida. UF Health will be one of those because they'll go to Shands Jacks, but Shands Jacks and UF Gainesville are considered one. So we'll get our allotment of vaccine, as will, I believe, Advent Health, Tampa General, Jackson Memorial in Miami, and 1 or 2 others that escape me right now. Those centers will get the vaccine and then start vaccinating their workforce. So in phase 1A from CDC and from the federal government guidance is going to be vaccinate the healthcare workforce in the US first. That's 21 million people. Also in phase 1, I think 1B is, and I might have the letter and number and designation off, but the next group that's going at or simultaneously is going to be long-term care facility residents, which is about 3 million people. So 24 million people will probably be vaccinated before mid to late January. That's phenomenal. And so those centers will vaccinate first, and they'll do it with Pfizer. So the Pfizer vaccine will come out first. Then Moderna will be approved probably after that. Moderna should be getting their EUA determination on the 21st of December. And the 1 week before is when Pfizer will get its determination, we expect, unless there's some dramatic surprise or some sort of late December surprise that we don't anticipate. And they'll ship out literally the next day. The trucks are like ready to launch. And it's a pretty dramatic thing that things are ready to move out. The Moderna vaccine will be a little bit easier, but I don't know at what scale it'll go out and how it'll be broken down. But Moderna will probably be reserved then for the next group of people, which are going to be high-risk individuals with high-risk conditions, and those who are elderly, so 65 and older. So when you put those two groups, that group will probably be the ones that start to get Moderna, depending on the timing of everything. And then the other vaccines will start coming in. So AstraZeneca, which is an adenovirus vector vaccine, and then also I think the J&J product will come out at around the same time, and that'll probably be early 21, so maybe into January, maybe as late as February. And then those start hitting out broader parts of the market. Those adenovirus ones, the AstraZeneca product is really easy to scale up. It's pretty cheap and easier to make. And then you're going to have I think their contract is to produce 1.2 billion doses in 2021. And both the Pfizer and the Moderna product will need to be given 3 and 4 weeks apart. You'll need to get two doses. And the thought is that, and you can't mix and match. So when you start with Pfizer, you get 2 Pfizer doses, not a Pfizer, then a Moderna. There's going to be mistakes. There's going to be times when it works. When that happens, it's probably not going to be a problem. But we're going to kind of stick with the 2 of the same together initially, until there's more data. So that's kind of what the initial phase will look like. I think that the average kind of person without risk factors, if I had to guess, will probably be getting vaccine sometime in late March, early April. Maybe a little bit later, depending on how much vaccine uptake and how, more importantly, I think, how good we are with logistics and how good we are with administration. So that's what probably concerns me the most. And the delays, I think, will come from some of the administrative hurdles, not at the federal level. That part seems to be moving along very nicely, but it's going to be at the state level that the challenges will be. Again, not casting any shade on anyone there, but it's just the idea that that's where the rubber meets the road, right? So in other words, you've actually got to do delivery, and depend on who's going to do it, it gets a little bit more difficult at the state level. So it's a little bit of a bigger lift. So it's exciting. I mean, I think this is going to happen, and I'm sort of expecting that our group will be getting the vaccine. I'm assuming, if not sometime at the end of this month, maybe early after the new year. So we expect to be vaccinated here real soon.
Excellent. So let's say that you're a UF employee, you're not in healthcare, and you're not in the over 65 or in have comorbidities, the high risk group. How will you get vaccinated? Would it be through UF somehow that UF Health would help vaccinate you? Would it be through your local physician or the hospital?
Yeah.
How will that be rolled out for UF employees in general?
Yeah, I think that's going to be where it's going to be just rolled out for the communities at that point. So kind of think of that. There's going to be sort of this sort of an arc. So initially you're going to have a significant demand and not a lot of supply. So you're going to have demand outstripping supply. Then it'll end up plateauing over some time, where you're going to have supply meeting demand. And that's probably going to be sometime, if I had to guess, is going to probably be in February, somewhere around that point. And then in March, supply is probably going to start to exceed demand and into April. So I think it'll probably be a combination of, Moderna will be able to be given in physicians' offices. Pfizer will probably never be given in physicians' office, right? It'll probably be at big vaccination centers, academic health centers with -80 refrigeration capability. And so that's where the difference will probably be. And then AstraZeneca and then the J&J product will probably be able to be given at any location. So I think that'll probably happen at scale. And we will just be broadly told, these are the vaccination centers, these are the doctor's offices that have it, this is where you go, and you'll be given a card that basically says that you've been immunized. Now, an important thing to remember is that we likely will have to continue to wear masks, yes, those beloved masks, after we get vaccinated, because we've just got to collect data on the fact that the vaccine did prevent illness. It did prevent you from getting COVID and having a positive test, but we don't know long-term and at scale whether or not it will give you asymptomatic infection and whether or not you can spread. So that's an important thing to kind of remember. And we'll probably have to wear masks even after the vaccine gets a significant rollout, but probably sometime in the early spring, late spring, early summer, that we will, in my opinion, my hope is that we start, quote unquote, getting back to normal after that.
Thanks. So one of the questions here was about vaccinations around the state with our county faculty and RACs. And what I think I just heard you say is that's going to be through vaccination centers around the state. Even in Gainesville, for most folks that aren't in healthcare or in these other categories, we're getting the first rollout. That's going to be through the regular healthcare provider or through vaccination.
Eventually, yeah, eventually it'll be there. But I think that probably before that, there'll be larger vaccine centers that will be able to kind of administer it. And when I say vaccine centers, Department of Health is going to stand up some sites. Academic centers are going to stand up sites. There are going to be other larger areas and kind of contractors that will end up setting up sites as well. So we're looking at trying to get 200 million people vaccinated by June in the United States. That's going to be a big job.
Yeah. So you don't want us to text you when we haven't been vaccinated in March.
Yeah, please don't.
Don't text you. Okay.
Yeah, that's okay. I mean, you can text me. Don't expect anything to happen afterwards. But
okay.
Yeah.
What about for folks that do not want to get the vaccine? Well, you mentioned you're getting a card when you get it. Are there any thoughts that UF will require vaccination to come back to work? We're hearing about airlines might require vaccination to travel internationally, and we do require vaccination for our school children, for example. What is UF planning in that regard?
Yeah, it's a great question and an important one that still needs to kind of be thought through a little bit. I think initially the reason why it's not going to be required is twofold. Is that this is a new vaccine. These are new vaccines, and we want to know how safe they are and how efficacious they are. And it's just for people to, again, go back to that point that we're all making difficult decisions. So people will have to decide for themselves: do I trust my doctor? Do I trust the data? Do I want to do this, or do I want to keep the epidemic ongoing? I mean, those are going to be the decisions that individuals will have to make. The more people that take the vaccine, the quicker this all ends and the quicker we get to the other side of this. But until we know with months of data after people get the vaccine in the general public under operational field conditions, what the issues are, it won't be required. But I suspect that probably by the end of 21, so probably early fall of next year, we're going to be requiring it in one way, shape, or form for certain activities. So on the healthcare side, it'll probably be required like the flu vaccine is. And there's gonna be some caveats. So again, that's a whole other legal set of complications and some other things that are there, but I don't anticipate it being required at least for 9 months to a year from now. And even there, that might still be a question mark. So there's no plans to make it required as of yet. Airlines can do that. They can allow that to be done because that's a privilege to be able to kind of use that service. And so we'll kind of see how this shakes out. It'll be interesting.
Okay, thanks. And a series of questions here. I think I can lump them together regarding how long immunity will last once you get a vaccine. Will it be required? What about those folks that have been naturally infected? We have 1 million cases in the state already. Should those folks get the vaccine going forward? Does the vaccine provide better immunity than or greater level of antibodies in natural infection? So the longevity of this and whether we're going to be required to be vaccinated year after year for coronavirus.
Yeah.
What are your thoughts on that?
Yeah, I think a very important aspect of being credible is to say when you don't know something, to say you don't know. And to answer all of your questions, honestly, I'd have to say I don't know on any of those, to be honest with you. But I'll tell you what the best guess is and kind of what my thoughts are with regard to that. I think in terms of kind of what the long-term plan is probably going to be is that the suspicion is that coronavirus immunity has been longer than what we thought initially. We thought, oh my gosh, it's going to be a few weeks or a month, or we really can't generate immunity to it. And the reality is that it's probably more than what we thought. And there's actually been some studies that have now shown that it could last as long as 2 or 3 years. And again, those are from more complicated studies, and there are obviously some sort of modeling there, right? Because it hasn't been 2 or 3 years since this has been around. So we really haven't been able to prove that. But it does seem to be more robust than what we anticipated. In terms of the million cases in Florida, that number's probably, truth be told, that number's probably about 3 to 4 million, right? So that's probably an underestimate of the number that we've truly had. Those individuals should get the vaccine eventually. We don't really understand which immunity would be better. I think that the vaccine immunity will probably be better and longer lasting, but we don't know. But in terms of priority, those who do not have health problems, who have already had COVID-19 infection, are at the very bottom of the list of people to get the vaccine. So in other words, they don't need to be the ones that are rushing to get the vaccine first, because their immunity will probably hold, and they're probably low risk for reinfection. So that's kind of where that stands. If you ask me what this looks like, I think we'll probably end up getting the COVID vaccine every 1 to 2 or 3 years, because immunity will probably be shorter lived than it is for, say, our childhood vaccines, childhood illness vaccines that we get with measles, mumps, rubella, but not as good as, or not as short as, say, the flu, which mutates a lot. For an RNA virus, the COVID is SARS-CoV-2 virus has been a lot more stable than anticipated. So not a lot of mutations. The spike protein doesn't change a whole lot, and so we think that we'll be able to have pretty good long-lasting immunity to the vaccine because of the vaccine.
That's great news.
Yeah, and there was a recent release, I think that Pfizer had, I believe, that said that people who've been infected can safely take the vaccine as well. So just in case you're infected, didn't know it, and now you get vaccinated, there's been no proof of harm. But that's going to be an area of close concern and close watching over time to see about negative side effects.
Okay. And so once someone is vaccinated, does that mean they fall off your radar for screen, test, and protect? Do they have to be screened anymore, go through testing, or will they still be?
In those cases, the only people that will get tested in that circumstance are going to be anybody who demonstrates symptoms. So there'll be no reason to routinely test somebody who's been vaccinated.
Okay. Great.
And in fact, what we're trying to do is to come up with a system so that if anybody who's tested positive within the previous 90 days will not be in our testing regime anyway, because we think that the immunity will last at least 90 days according to CDC guidance, which is out there. So yeah, and also if the numbers go down before vaccines get widespread, we may be able to tailor down our testing before vaccines get widely disseminated. So I'm optimistic that this will start winding down even as we start to get the vaccine rolled out.
Okay, excellent. There's another question there I think I can answer, which is regarding antibodies after vaccination and how you would test that. We have a study in IFAS going on right now through a microbiology department on antibody presence, and we're going to modify the study now to ask questions about when you're vaccinated, so they know whether you're achieving antibodies through natural infection versus vaccination, and so we'll be able to track that a little bit for IFAS. So.
Yeah, I think that's going to be a very important question to answer as far as like what is the impact, and then do people get reinfected? What to answer that question you asked earlier as far as what's a better source of immunity, right? So previous infection or the vaccine, because we're going to have people that are going to refuse the vaccine who've already been infected, and we're going to have people who weren't infected who got vaccinated, and somebody in there is going to get COVID. So I think that's going to be an interesting kind of thing for us to follow on a big scale.
Right. Well, Dr. Lozardo, we've come to the end of our hour. It's always so informative. I get so many, such great feedback from everybody that attends these sessions and listens to the recording. We really appreciate your time. I'm reminded of the quote from Winston Churchill. It might not be the beginning of the end, but at least we're at the end of the beginning. It sounds more impressive when you're able to talk like Winston Churchill with his accent. I'll work on that next time. But
yeah, why is it that we just love British accents so much? It just sounds so, impressive. But yeah, I hear you loud and clear. And that's one of my favorite quotes of his. So. And I also like his that, what was it that he's a very well-known lover of all things American, having been, I guess his mom was American, but he said, Americans always do the right thing, but only after exhausting all other possibilities. And then eventually only after exhausting all other possibilities. And I don't know if we've been quite that bad about it, but there are a lot of things that I wish we would have done differently. But regardless, I think we're heading in a very, very good direction. So I'm very excited.
Well, thanks again for your time, and we'll invite you back in the spring again for another update on this as we go forward.
Well, no, you're very welcome. And thanks so much for inviting me again. And then also, again, seriously, if there are those questions or concerns before that session, we'll do our best to answer them and try to get you taken care of. So have a great holidays to everybody. And again, we're here to serve and help you. And if there's anything we can do to help you, please let us know. But thanks for your time. And again, thanks for the invitation.
Thank you. Thanks everyone for joining. Take care.
Bye-bye.